Before we begin, we'd like to acknowledge that we are recording on the traditional country of the Kaurna people of the Adelaide Plains. We pay respects to elders past and present. We pass that respect to any Aboriginal or Torres Strait Islander listeners. Hello and welcome to From the Heart. I'm a heart parent and your host, Sami Glastonbury. Today we are diving into a topic that many families in our community face: feeding and speech development after heart surgery. Joining me is Emily Hayes, a speech pathologist and feeding therapist who works closely with babies and young children, including those who have had surgery or spent time in intensive care.
When you're in that really acute setting, keeping that baby healthy from a medical point of view is the priority. You will probably have a feeding team around you. So you'll have a dietitian, you'll have a speech pathologist, you'll have a paediatrician and your heart surgeon, and everyone will be talking together to support you through that process.
If your child has used a nasogastric tube, had difficulty feeding, or if you're just wondering, should you be concerned about speech delays, this conversation's for you. So, a very warm welcome to you, Emily.
Thanks, Sami. Very kind of you to have me.
We're really excited for this conversation, and we're excited just for so many of our families to hear it. I know that we get lots of questions through our helpline and our chat, just trying to navigate this space. So I think the conversation is going to be really quite timely. So Emily, to begin, can you share a little bit about your role, your sort of key areas of interest, and the kinds of patients and families that you typically work with?
So my base degree is speech pathology, but I have done most of my ongoing professional development in the area of paediatric feeding and have worked in, inpatient setting, like an acute care hospital sort of setting, and now I have my own private practice. So most of my caseload is paediatric feeding. So they vary in age, right up to 100, as long as it's about meal times. That's my area of interest and what I help people with. But with the paediatric population, often they might be either really medic complex and may or may not have a nasogastric tube involved. They may be neurodivergent or have some sort of global developmental delay or syndrome, something impacting their development, and most specifically having some real issues with their eating and drinking.
Okay, so because you're a speech pathologist, but then you're sharing a lot around meal times, how does speech and feeding development, how do they go hand in hand? How can you explain to our audience how they link?
Yeah, absolutely. So I believe very traditionally, speech pathologists became involved with dysphagia, which is a disordered swallow, in hospitals when no one really knew what to do with the people having trouble with swallows. And so the doctors were like, well, it's the same muscles that the speech paths work with, so we'll get the speech paths to work it out. So
wow, I didn't know that.
Yeah, that was what I was told when I worked in the hospital system. So I guess, that's logical. It is the same. So, we learn it's the same anatomy, it's the same motor plans, it's the same area. It involves breath control and, the oromotor muscles. So that's the link.
Yeah, okay. So for families whose child is, if you've got a child and you're preparing for surgery, which is a lot of our families, is obviously we get the diagnosis, then we're usually told, well, it depends obviously on whether the child needs emergency surgery straight after birth, or like in my case, you go home with your baby and then you get called up for surgery. Is there anything that we can do to prepare? Because a lot of our children end up on an NG tube after surgery. And then just depending on their recovery, is there anything that we can do to prepare for that?
It's really hard with the, babies waiting for heart surgery. The focus for really all the team, the parents, the emotion is around making sure that baby is safe and okay. So that medical sort of, the medical stuff trumps all the developmental stuff at that stage. So really just trying to stay as relaxed as you can about it, really. Knowing that, yes, they might come out of surgery with a nasogastric tube, but there's lots of people there ready that are going to give you really strong support with how to manage that and how to move through that, and hopefully in the future get rid of that.
That's really great advice and really, I suppose, comforting to hear, because I think as parents, we try to think of how can we best prepare? How can we make this road a little less bumpy? So it's really nice to hear you say, for the moment, just pop that to the side and just concentrate on getting your child through that medical episode or that medical intervention that's about to happen. So on the flip side, we've come through surgery. What should we start to expect in the respect of maybe the tube's got to stay in? Do we try and feed? Like if we're breastfeeding, do we still try and breastfeed while the NG tube is still in? Or, what thoughts do you have around that?
Yeah, absolutely. So again, when you're an inpatient in that really acute stage in the hospital, you will have a team around you, although that team may or may not be as familiar as once you're discharged. You obviously often end up with the same therapist for a really long time and can develop really close relationships with them. So again, when you're in that really acute setting, it is about often the doctor is trumping the allied health decisions at that point, because keeping that baby healthy from a medical point of view is the priority. So it is absolutely okay to breastfeed and nasogastric feed at the same time. A nasogastric feed doesn't interfere with oral feeding. So when I say oral feeding, it's through the mouth. So yeah, you can absolutely do both. And, you will probably have a feeding team around you. So you'll have a dietitian, you'll have a speech pathologist, you'll have a paediatrician and your heart surgeon, and everyone will be talking together to support you through that process.
So I love that. I love that you're really just endorsing us just to be mum or be dad or be caregiver.
Yeah.
Play our role in nurturing, allow the medical professionals to play their role. So a lot of feedback that we get is because some of our children with COHD are in hospital for quite lengthy times, depending on the type of surgery, or they've had to go back and have recurrent surgery, or they could be waiting for some other sort of medical intervention. Is there a point in which you generally start to see when children leave that acute setting, like you touched on before, the milestones? Are you expecting us to sort of see you straight away, or do you think that will be referred? Or when do you think that we should start to think, hang on a minute, we're home now, we're getting back into a routine, but we're starting to see either a speech delay or a feeding? Do you call it a delay? Is it a feeding delay?
Yeah. So sometimes it's a delay, sometimes it's a disorder. So a delay is if everything's going absolutely tick box as per a paediatric child, but you're just a few months behind or a few weeks behind. Whereas a disorder is if something is happening which wouldn't typically be happening to a typically developing child. And kids going through the sort of medical stuff that your kids are going to be going through are at risk of both those things, both delay and disorder, because their experience is really outside the norm. So they often have different reactions to feeding because of their early experiences with feeding. So you go.
I'm going to say, so what are the most common things that you would see then?
So I guess there's a couple of things going on. So the nature of a sick child is that they have less resource to learn. So their bodies are focusing really hard on just surviving, really. So just like you and I, when we've got the flu, if we are not feeling well, we might read a really light romance novel. We're not going to pick up a textbook and, start learning Chinese or something at that stage. So it's just like that for them. They just don't really have capacity to learn. So, when they're really unwell, absolutely the best thing the parent can do is just show them love and make sure that attachment is happening as well as possible, so that when they are well, they're in the best sort of regulation and mental place to learn. The other thing that unfortunately happens for many of these children is that they spend a lot of time in hospital, which actually means they miss opportunities for learning. So when you're in a hospital room, there is not grass on the ground. There isn't birds chirping in the background, but there is lots of really loud noises that are beeping, and the night and day is different. And there's lots of different people coming in and touching them in spots that they wouldn't necessarily be touched if they were at home with a parent. So their experience is very different. So they have these different experiences plus these missed opportunities to learn. and socialise, really. Yeah.
I love how you kick that off, that just like when we would get the flu, I just need to share that Emily has 4 children, and I don't think you got a chance to pick up a romance novel just quietly. And
They're a bit older.
I know, but at the time, sorry, I just want to put that into perspective to everyone that's listening, is Emily's obviously got plenty of years of experience in this particular area, but also too, she has the lived experience of raising 4 children, I'm sure 4 very different children. So, but I actually love the fact that you referred to just that they don't have the resources and they don't have that opportunity, because I know that a lot of parents, they reflect, are there things that they could have done better, or are there areas of which now, like you were just referring to, the beeping, the touching, is there areas which I could have avoided a little bit of that trauma, so to speak? Trauma is a heavy word to use, but sometimes that's where our children can find, they can find that whole experience. So I love the fact that you're even just talking about this in a way that it's this kind of the state of play. They haven't had the opportunities, they haven't had the resources. It's nothing that anyone could have foreseen or changed. Would I be right in saying that?
Yeah, I think so. And yeah, you use the word trauma, and I'm not sure that is too light a word always, because it is a really intense experience. So you speak to, a first-time parent of a typically developing child, and they will explain that often as the biggest thing that's ever happened in their life. And when you think about you imagine your life with a baby, it is not sitting in a hospital room.
No.
It's not what you've imagined. So you're grieving for a life that you are now not experiencing. You're experiencing this different life. You also are in an acute care setting where you have lots of staff turnover, you have people coming in and out, you have different specialists, and you have some of the specialists are brilliant at what they do, but maybe they don't have great EQ, and maybe the nurse that day is just having a bad day, or the doctor's having a bad day, and they say something to you. And I hear lots and lots of parents come out of that hospital system, and they really do. The parent and the child has a bit of medical trauma. So the child sort of will often get upset when they have to present back to one of those rooms in the hospital. And the parents have often had an experience where they felt really not listened to, disempowered, and it can be really challenging. And I think it's important that we all understand that's a really intense environment, and any professional would be devastated that they have contributed to that. But, sometimes they don't have the lived experience, or as I said, they're having a bad day too. And, maybe they've just had a really terrible experience with a client before you, and, they're humans. So I think it is worth mentioning that can be traumatic, and that sometimes when you're in that hospital environment, you've got to look after yourself and just get through that. And I would hope no parent ever beat themselves up about not doing everything perfectly in that environment, because it is not a normal environment. And you're often in a state of anxiety during that time. So even if you can just relish and enjoy and delight in something, that attachment and any normal interaction will help contribute to the child-parent relationship that, once you're out of that environment, is going to support that child's development in the best way possible.
I think that's brilliant advice, everything you've just said there, Emily. That bond, like you said, and I'm just reflecting on sort of my own personal journey, and it's that bond, and that's that bond that puts you in good stead, because it's that trust that when they look at you, when you're taking them off to another therapist or another specialist, they look to you regardless if at that stage they're verbal or not. Do you know what I mean? Those little eyes are looking back at you as if to say, Mum, is this okay? Or Dad or caregiver, whoever's in there, who's holding them in their arms. So I think it's great that you're sharing that, but also too, you're just really giving into that empowerment piece of, we have a really vital role to play, and that is to bond and to care. And it's hard in crazy environment, but you're right, we need to focus on that a little bit more. It's hard obviously in the moment, but that's where we hope this podcast really helps, that someone's listening to this now, as we only just got an email today around someone reaching out to say, I'm in hospital now and I've been listening to the podcast, and it's really helped me sort of process what's coming next. So changing sort of tone here just a little bit. So
Yeah.
we've chatted obviously about your role, what you see, how we can play a role to understand, let the medical professionals play their role. What is something that you do see though in a child with either COHD or someone with a really medically complex? What are some of the things that you do see from that oral development or communication delay? What's something that you usually
Sure.
see after sort of that acute setting?
Yep. I'm going to separate it into communication and feeding because in
Sure.
my head, I separate it.
Sure.
So I will often see a child for feeding, for example, and they will see a different speech pathologist for communication. So they are two completely different developmental areas. And I think that point alone is what often makes the feeding so challenging is, again, when you look forward to having children, you think about the fact that they're going to start crawling and then they'll cruise and then they'll walk and, then they'll say their goos and gars and then they start their words. But no one actually thinks of feeding as a developmental sort of process. And it is. So, yeah, I will separate those two things if it's okay.
No, absolutely. But I think it's really important for us to learn and hear this, because if we don't have these conversations, you'd lump it all in. You're a speech pathologist, so you must do it all.
Yeah, that's right. And I think the feeding difficulties for your types of families are often far more challenging to deal with than the communication. So communication is something that lots of kids are a bit delayed and, everyone sort of understands, oh, your kid's been a bit sick. Of course, they're a bit slow with their talking. And there's often sort of a few ways you can supplement along the way. Whereas often the more extended family and friends really struggle to understand what's going on with the feeding, and they don't understand why there are feeding issues. How is the heart related to feeding issues? Or just because you've been in hospital, why are there issues with feeding? So it's often a lot more emotive for the parent, the feeding side of it. We are really wired from sort of caveman days to feed our children in times of scarce food. So it's quite an internal emotive drive to feed your child. And I think parents, they can really deal with a bit of a communication delay, whereas they often get a real sense of failure when they can't feed their child. And lots of your babies, the parents are going to have that taken out of their hands. And someone will support you through it on the way through. But the chances are you're going to be feeling really alone for some of this journey because other parents, you won't be able to go to other parents and say, my kid doesn't eat. What do you do? Because they'll think you're crazy because their kid just eats and they never thought about how that happened.
Yeah, it's so, even just you saying that, you're right. I think this is the easy part. I can't do, I can't fix your heart. I can't put a catheter in. I can't do this. I can't do that. But I can't remove a cannula, but I should be able to load up this spoon and zoom it into your mouth, and you should just know how to chew, chew, chew and swallow without aspirating.
Yeah. And eating's quite complex. It's a really complex thing. So as you say, lots of your little heart babies have got nasogastric tubes in. So the heart impacts feeding for lots of reasons, but an easy one to sort of get your head around is you have to hold your breath to swallow, because we have to protect our airway. So we've got two little holes that are quite close together. One goes to the stomach, one goes to the lungs. So we have to hold our breath in order to swallow. So if your heart's not great, obviously often the rest rate's a bit higher. Your body's working really hard. Now, Sami, you and I don't go for a jog and have a cup of coffee at the same time. When we're huffing and puffing and we're working hard, we sit, we rest, we slow down, and then we have a drink. So, even that sort of medical complexity makes it harder for them to eat. So they've got that going on in the background. They're getting fed by a nasogastric tube because often sort of that growth and the nutrition is so important from a health perspective. Sometimes they need to put on a certain amount of weight before the surgery will happen, and they need certain nutrients to be right. And that's, outside my scope, but I know they need to eat before surgery. So that's why the nasogastric tube goes in. The doctors can do medications through there as well. So that's really important. But when that happens, they miss out again, it's a missed opportunity. So they might not be breastfeeding for a few days because they're just not up to it, or however old they are. I don't know if they're all babies, I imagine at various ages, but they're missing eating opportunities. So they're not seeing the food or the drink. They're not smelling the food and the drink. They're not getting some of it dripping down their face or getting it on their hand, let alone feeling it in their mouth. So when we're eating or drinking, so feeding refers to eating and drinking. So when they're feeding, they're smelling and tasting and feeling these foods, milk, whatever it is in their mouth. When they're nasogastrically fed, the feed goes straight into their stomach and they miss all that learning opportunity. And they're not practicing sucking and swallowing as infants. They're not developing that strength and coordination. They're not developing information about where food is in their mouth. So when they then start to grow with those skills, they might find it really hard to find bits of food in their mouth. So, they might put a whole lot in as a toddler because I don't know where it is and I only feel safe if I know where it is. So I'm going to put that whole piece of bread in and then at least I know where it is, but then I don't know what to do with that. So they miss all these learning opportunities on the way. So they're often delayed because of that. So if we go back to that delay disorder, but they also have a tube going down into their stomach so they can feel something at the back of their throat. They're often, maybe they're on oxygen as well. So they've got tape on their face as well. Maybe they're getting injections, they're getting touched, they're getting wiped, they're getting cleaned. They're having all these experiences that can make them quite orally averse. So they just don't want anyone to look in their mouth again. And could you just stop touching my face? And it's quite overwhelming. So that can actually change the way they process sensory information.
That's everything that I just took from that conversation is around the fact, I think we simplify it, don't we? We go, feeding. You just get a spoon or you get a fork, you stab it in some food, or you get a banana, you peel it, you eat it, and you should just know what to do. But like you're almost saying, it's almost like we have to advertise it. We need to smell it, see it, touch it, feel it. We need to probably... Are we also looking? We're looking at our parents and how they're eating, or siblings, or whatever it is. It sounds like we've probably downplayed it, haven't we? We've downplayed feeding. Like you said, it's almost like it's caveman-like. You must eat and you will enjoy, and that's that. Tick, box, done.
And I think that hospital environment really plays with that, doesn't it? Because, the primary carer is just surviving. So they're probably eating hospital food too. They're probably not particularly enjoying their food. They're eating food when it comes, or probably when the baby's sleeping.
Absolutely.
So then again, baby misses out on all those opportunities. Mealtimes are about so much more than this food. So they miss out on all of that food, but they also miss out where other babies are experiencing mum and dad or mum and grandma coming together at the end of the day, sharing about their day while they've got baby popping on the lap, and there's lots of happy, calm chat, and that mealtimes are about connection. All our celebrations are based around particular foods and mealtimes, and they miss out on a lot of that when they're in hospital. And, it has a really big impact on these children, and there's nothing as a parent you can do to recreate that. You can eat with them and you can make it fun and you can do some positive stuff in that hospital room, but you can't, the child has to be well from a medical point of view. You can't just whip them home for Christmas lunch because it's the 25th of December if they're having their operation tomorrow or they've had it yesterday.
Yeah, all incredibly insightful. And it's one of those conversations that, again, Emily, I wish I knew that. I wish I knew that before. And as you know, I was blessed with two very healthy children. So when I had Frank, this was all new territory for me. And I took it, I think I took it for granted. I'm just going to say it. I took it for granted. I took it for granted that my girls reached all their milestones. I remember checking the book after going, what are they meant to be doing now? Oh, they're doing it. Okay, good. Put the book down. To then be in a world of delay and disorders and so forth. So is there, if we skip forward, we're now out of hospital.
Can we skip back to hospital for a sec, Sami?
Yeah, skip back.
Because I feel like I've given a negative picture on it, because
not at all.
I think taking in mind all those points I said about that, the meal times in hospital, you can do some delighting around that, and you can make a decision to eat your meal while your baby is awake and on your lap. And they're going to experience that food that you're eating. And maybe the siblings or dad or someone else special in your life brings in, fried rice instead of
something,
whatever terrible thing the hospital served up to you. And, you can have those experiences in the hospital room if you have capacity to do it amongst everything else that is going on. And a sibling can come in and enjoy a Freddo frog, and the baby can sense that and experience that too.
No. And I think if anything, you've just helped. I think you've taken the curtains down, which is actually really nice, because I think there is that thinking and feeling sometimes, like I've just said, I wish I knew, is it's almost like the curtains are closed. You've actually just pulled them back and have gone, do you know what? You're doing everything you can. You're here, you're nurturing your baby, you're talking to your baby, you're comforting your baby. You're that trust person for them. And I think we have to, like you said, be kind to ourselves and understand that we're not going to know these things. And don't get me wrong, it's great to share this podcast. And I'm sure there's going to be plenty of people are on the journey and will take this into their next surgery. Or it could be someone like myself after the fact going, oh gosh, that makes complete sense, that it is a development thing. It's not just how to eat. You just wake up one day and, like you say, when explaining it like you did, are we having our coffee and running? There's a lot of mums listening saying, I'm pretty sure I do that.
That's for sure, yeah. It is a really complex thing. So, you have to have actually quite good physical skills to be able to sit up, to start to learn to eat solid foods. You need quite good interoception. You need to know where food is in your mouth, and you need to be able to feel that. You need to be able to recognise that you're hungry. So lots of these babies have actually missed that opportunity.
You're right, because if your tummy's just being filled up.
Absolutely. So we start off sort of eating reflexively, and then as we mature, the reflex gets integrated and we learn as a behaviour. So you start to recognise that funny feeling in my tummy is I'm hungry. And then I cry, and then I get something in my tummy and I get that lovely satiated feeling, and then it's all, that's great. And then I forget about it for 2 hours, and then it comes back again. And so the cycle goes. And then now I understand hungry and full. These babies have not had that opportunity. So they often have to be fed sort of not, and this is sort of the dietitian area, but often they need to be fed really long and slow across the day for whatever reason. So it might be maintaining sugar levels, or it might be that they reflux because they're spending a lot of time lying down. So they might reflux more. Plus they have a tube down through the sphincter, which might let a little bit through. So, and then they might vomit if they're given too much volume at once. So they often have missed that opportunity to understand, and they're fed to a timer. The nurse's alarm goes off, she comes in, goes the feed, baby's full. So they really do miss that hungry, full
You're
stuff.
taking me back. You're taking me back. I'm literally inside the Women's and Kids Hospital right now. As you say that, it was. A timer went off and off we went. It's a really good conversation. As I said, it's a great conversation about someone who's early in the journey, who's post-surgery thinking, okay, this is great. I don't have to kick or beat myself up. It's nothing that I did. It's nothing that I could have prevented. I think that's really key to get across to our audience. So if we move sort of in a different age bracket, so to speak, we've spoken a lot around obviously those babies, and I'm sort of saying maybe under the age of 12 months, probably more particularly. So do we see delays and things in older children? Like, have you come across in your practice or in your career where maybe there's a child that has had some sort of medical complexity, but it's now they're 5, 6 or 7 and you're starting and mum's presenting or caregiver's presenting with X, Y, and Z. And then do you dig a little bit deeper and go, that's because of...
Yeah, I mean, it's always a guessing game, but, it's always... it's part of what I love about my job, right? You present me with the puzzle and I will do my absolute best to work out perhaps where this breakdown has occurred. But you look, absolutely, and that challenging time early on can impact later. So they can miss windows of opportunity to learn about textures and tastes and things. And again, with feeding, it is complex. It uses every single one of our senses all at once. And it's nearly the only thing as humans we do that involve every single one of our senses at once. So if they have, missed some of those opportunities with learning about sensory processing, and often with these babies too, they might be just hanging on and it's okay, and the family are okay. Or maybe the focus is still on the medical stuff, and they're really delayed with their speech, and we're seeing the physio and we're getting them all nice and strong. And oh my God, they're starting kindy tomorrow. Actually, they only eat 4 foods. What? Oh, they only eat when they're with.
Yes.
Oh, this is suddenly a really big problem.
Yes.
So that absolutely does happen. And they might also be tracking along okay, and maybe some anxiety starts to kick off. And I think just like in adults, food is one of the few things we really have quite a lot of control over. And kids might be anxious about who knows what, but if that was something that was challenging early on, we sort of managed to do it and everything was going really well. So I'm just getting by. And then something else pops up and it's stressful for the child. And they hit a bit of a brick wall about something, anxiety increases. Food is often what they will then control. They will often drop food. They'll get hypervigilant about the way food is presented. So I used to eat, a ham and pineapple pizza from everywhere, but now I will only eat a frozen McCain ham and pineapple pizza because one from the local takeaway shop's completely different in their mind and they won't have it.
Okay.
So that those sort of that hypervigilance, that rigidity in their thinking can all kick in at a different stage and start to have that snowball effect on dropping foods and finding the concept of the mealtime more challenging.
So, Emily, so much to take on of what you've said tonight, but incredibly, I don't know, it's insightful, it's informative. I've almost had a history lesson. I feel empowered. I don't have to feel bad about myself. There's nothing I should have done other than just basically be there for my child, celebrate moments, hug them, be close, play that true role. And then when we're experiencing that next stage of obviously needing intervention, that's when we call upon yourself. So if a parent's listening tonight and thinks their child might need support by a pathologist, a speech pathologist, or someone like yourself who's is a feeding therapist with many years of experience, what's the best first step they can take?
Yeah, so the first step is a bit of a Google, find who's local to your area, so you're not traveling a really long way. Look for someone who has done some extra study and has a real special interest in feeding. It is a little bit of a niche area. There's quite a few in South Australia. So just, have a chat to them and make sure you feel comfortable with them, because there are different ways of working with children with speech and language issues and feeding issues. And you need to find a therapist that you feel really comfortable with. So I think that's, I would spend time having, if I had to, 3 or 4 initial assessments until I felt really comfortable with who it was. And I felt like I was going to make a good family connection. It's a really, I think your allied health professionals, don't underestimate them. So we really often have a little bit more time than the medical profession had. They often have people coming in and out really quickly. They're in a really medical setting. We really have the privilege of time. We get to know the parents. We get to know the child. I might take 3 sessions for a child with a bit of that medical trauma before they will come up to me and be happy with me and start to interact. And then I might be involved with that family for 5 years. I won't always be, but I might be. So you definitely want to feel really comfortable with who you're contacting.
And especially too, I think, because we touched on that piece of it's probably stemmed from a potentially traumatic experience in acute. So
Yep.
this is a part of, I suppose, their healing journey. And you're a part of that healing journey of opening up that door and I suppose providing those opportunities that you've quite rightly pointed out are missed. And are missed for only medical reasons, not because of anything that anyone has sort of done, so to speak. Well, thank you, Emily. Thank you so much. I know that this podcast is going to be so incredibly powerful for so many people listening before, after, during anything. And it's great to know that there's people who have taken such a keen interest in this area. So thank you.
Oh, absolute pleasure. Thank you.
Sometimes this podcast talks about some heavy things. If this brings up anything for you or someone you love, it is important to reach out for support. The HeartKids helpline provides support and guidance for anyone impacted by CHD. You can call the helpline on 1800 432 785. To access more information about CHD, as well as support from HeartKids, visit the website at heartkids.org.au. The information on this podcast is not a substitute for medical advice from your doctor or healthcare team. Always talk to your doctor about matters that affect you or your family's health.